Hello, I'm Dr. Nina Kim from the University of Washington. Today I will be discussing occupational hepatitis B post-exposure prophylaxis. There are 5 basic questions to address when considering post-exposure prophylaxis for hepatitis B. 1. How risky is this exposure? 2. What should the exposed person do immediately? 3. How do I know if hepatitis B post-exposure prophylaxis is needed? 4. What prophylaxis should be given and when? And finally, what follow-up is required? For the purpose of this mini lecture, I will be focusing on the last 3 questions in bold. When answering the question, how do I know if hepatitis B PEP is needed? There are 2 key pieces of data to know: the Hep B immune status of the exposed and the hepatitis B surface antigen status of the source. As for what prophylaxis should be given, there are 2 main options: the hepatitis B vaccine and hepatitis B immune globulin. So let's start off with a case. A nurse accidentally sticks herself with a needle after drawing blood from a confused patient in the emergency room. The patient has a history of injection drug use. What happens next? To answer the question how one knows if hepatitis B PEP is necessary, we need to know first the exposed individual's hepatitis B immune status. For this, we need to know the vaccination history, any prior hepatitis B serologic testing, including post-vaccination hepatitis B surface antibody testing, and history of hepatitis B, if any. Vaccine coverage of healthcare workers is not universal. Only an estimated 67% have ever received hepatitis B immunization, so one cannot assume this is completed in all individuals. Post-vaccination testing 1 to 2 months after completing immunization is indicated for all healthcare workers to assess surface antibody seroconversion. History of hepatitis B is not always available since hepatitis B is often clinically silent, but the reason some individuals have not developed surface antibody seroconversion after a vaccination may be because they have chronic hepatitis B. It is for this reason that the CDC recommends the full 3 tests or triple panel surface antigen, surface antibody, core antibody testing to assess all adults 18 or older at least once in their lifetime. If this testing is available, it can be helpful. Ultimately, our goal is to know if this individual has hepatitis B immunity, defined as the surface antibody titer greater than 10. This threshold may differ slightly depending on the assay used. Let's return to our nurse in the emergency room. She completed a recombinant hepatitis B vaccine series 10 years ago, and her post-vaccination testing at that time revealed that she had positive hepatitis B surface antibody to greater than 100 international units per liter. Her core antibody and surface antigen were negative, consistent with a profile of vaccine-induced immunity. In this scenario, hepatitis B post-exposure prophylaxis would not be indicated, as the exposed individual is considered to have immune protection. No hepatitis B testing is needed for the source person, although other testing, for example for HIV, may be indicated. Let's consider another scenario. What if the nurse never received hepatitis B immunization? Hepatitis B serologic testing is done, which shows the presence of surface antibody at a level of 20 IU per liter, and presence of core antibody as well. The core antibody would be positive if the individual has been previously exposed to the virus. This profile, where the surface antibody is also positive, indicates that this person cleared the infection and went on to develop surface antibody. In this setting, she is considered to have natural immunity. So just as with vaccine-induced immunity, in those with natural immunity, hepatitis B post-exposure prophylaxis would not be indicated, as the exposed individual is considered to have immune protection. Let's review a third scenario. Here, our ER nurse did complete immunization, but her post-vaccination hepatitis B serology showed that she did not mount an antibody response, and her core antibody and surface antigen were also negative, indicating that this vaccine non-response was not due to chronic infection. Someone with this profile is considered susceptible to hepatitis B. About 5 to 10% of individuals have no response to a 3-dose hepatitis B vaccine series. And moreover, not everyone necessarily completes their series. Non-response to hepatitis B vaccine series can be due to host factors such as obesity, diabetes, or genetic differences in immunologic response. In this scenario, where the exposed worker is susceptible and the source's hepatitis B status is not known, the CDC recommends combination prophylaxis, vaccine plus hepatitis B immune globulin. These interventions together have been shown to be more effective than either modality alone, providing both immediate and long-term protection, and does not interfere with the development of active immunity when administered concurrently at different sites. Protective efficacy diminishes with the passage of time from exposure, so prompt administration and no later than 7 days is key to protecting this individual from hepatitis B. The hepatitis B vaccine is really the mainstay of all prevention efforts, including after an occupational exposure. For adults, we have 4 options for immunization, with dose schedules as shown. I won't go through these in detail, but will direct you to our immunization lesson. The link can be found below in our description. But I will note that Heplisav-B, which is the newest form of vaccine that contains a different adjuvant and oligonucleotide compared with other alum-adjuvanted vaccines, would be a preferred option for those who are non-responders to other vaccines, given higher rates of seroconversion for both initial and revaccination series. Hepatitis B immune globulin provides passive immunity and more immediate antibody-based protection before vaccine-induced seroprotection develops. It should be given as a 0.6 ml per kilogram intramuscular injection, generally administered in a separate anatomic site, usually the opposite limb, from the vaccine. HBV is generally well tolerated, but rare hypersensitivity reactions can occur, particularly in individuals with IgA deficiency. Let's consider a 4th scenario. Here, we have a nurse who remains susceptible despite immunization, but this time the source has chronic hepatitis B. The recommended course of action is the same as with the prior scenario, where the source's hepatitis B status was not known. If the source is known to have chronic or acute hepatitis B, then both vaccine and HBV should be administered as soon as possible. Let's consider the final scenario. Here, our ER nurse completed 2 rounds of immunization series with no response. The source is known to have chronic hepatitis B. In this instance of a worker who has undergone 2 or more hepatitis B vaccine series with no response, it is advised to give an additional dose of HBV 4 weeks from the initial dose to ensure that the duration of passive immunity is extended in the event that they do not respond to this additional series of vaccine. Baseline and follow-up testing is recommended for workers exposed to a source who is hepatitis B surface antigen positive or whose Hep B status is not known, and who had non-response to hepatitis B vaccine or were unvaccinated or incompletely vaccinated in the past. The goal of baseline testing here is to determine if they are naive to hepatitis B and therefore susceptible, and we do so with a core antibody. In the case of the 6-month follow-up testing with core antibody and surface antigen, it is to see if they have developed active infection as a result of the exposure. And of course, there's the post-vaccination surface antibody testing as noted previously. Note that we're not testing for surface antibody at baseline. This is not necessary and can potentially mislead, since the surface antibody assessment of protective immunity really has been validated in those who have completed immunization. Be sure to check out our hepatitis B online lesson on occupational post-exposure prophylaxis. You can find this in a link in the description as well as on our website. Thank you for tuning in.
The production of this Hepatitis B online mini lecture was supported by funding from the Centers for Disease Control and Prevention.